guest speaker all the way from Calcutta, who's going to be talking to us about radiology and neuro-ophthalmology. So look forward to hearing you. We heard a lot about you. I was thinking you would be there for our conference at Calcutta, but the fact that we could get you on the virtual webinar, we are truly lucky. Thanks to Dr. Sujata Guha. On to you, Dr. Sumita. You could share your slide. You could unmute yourself and start talking. Thanks a lot, Dr. Santosh, Dr. Usha Kim, Dr. Ashok Grover, for being with me for this brief oculoplasty session.
Can you hear me now?
Yes, I can hear you.
Yes. Thank you so much, Dr. Chitra and your team, for having me here today and accommodating me, though I'm a little late. My topic of presentation will be radiology and neuro-ophthalmology, when it would translate to a better management. One second, and there is some technical glitch here. Six minutes to be. Okay. Diagnostic imaging is a major component of evaluation and management of neuro-ophthalmological disorders. It is imperative for the radiologist to get relevant clinical information from the neuro-ophthalmologist so that expensive investigations like CT and MRI can be tailored for each patient's particular problem. To evaluate the orbital and visual pathway as well as the cranial nerves and other brain structures, MRI is the superior modality compared to CT, particularly 3 Tesla MRI with contrast. X-ray skull does not have as much role nowadays as CT and MRI. Dedicated orbital USG with high frequency transducer and Doppler studies can be helpful in certain scenarios. The common indications, as we all know, are acute and chronic unilateral or bilateral visual impairment, fundal abnormalities, ocular motility disorders, hemifacial spasm, congenital and acquired cranial nerve abnormalities, and other congenital brain disorders. Just a introduction, like if CT scan is there, then it can be helpful for SOLs calcifications, radiopaque foreign bodies, and orbital wall pathologies, including evaluation of orbital fractures and tumors. But it is MRI of the brain and spine which plays an important role in differentiation between multiple sclerosis versus neuromyelitis optica spectrum disorder in patients who are coming with features of optic neuritis. The distribution of the lesions in the brain and in the cord differs between multiple sclerosis and NMO. Here we have short segment and small focal lesions in the cord and typical distribution in the brain in MS, whereas the distribution is little different and with long segment extensive involvement of the cord in the neuromyelitis optica. As far as retinoblastoma is concerned, both CT and MRI play a role, but CA-MRI is superior in evaluation of extraocular and intracranial extensions and also in evaluation of trilateral and quadrilateral retinoblastomas. Optic nerve gliomas, of course, you can see how beautifully MRI is showing this extensive optic nerve glioma involving almost the entire optic nerve as well as the optic chiasmatic regions, and the contrast study is showing areas of solid and cystic components. MRI has a very important role to play in evaluation of idiopathic intracranial hypertension. It's not that always we can give the answer, but very often we can show tortuosity of the intraorbital optic nerves and widening of the perineural CSF, partial empty cellular turcica, and MR venogram may show stenosis of the transverse sinuses. Intracranial neoplasms causing visual impairment, of course, MRI or CT would be helpful in both. This is a patient with a large enhancing mass in the left parieto-occipital lobe. Patient is having raised intracranial tension. We can see that there is bulging of the optic nerve heads. This lesion has a lot of blood degradation products within it. And in the perfusion-weighted image, there is not much of hyperperfusion. So all these together point to the fact that this is most likely not a malignant lesion, but something which has a lot of blood degradation products like a cavernous angioma. Of course, these are routine MRI brains which are showing cellular and supracellular lesions, which can lead to visual problems, and also cranial nerve pathologies like in this cavernous sinus schwannoma. Congenital disorders like septo-optic dysplasia. This little baby was born blind and she was named Gandhari by her adopted home. We can see that the interventricular septum is absent, box-like ventricles, bilateral microphthalmia in septo-optic dysplasia. In leukodystrophies, of course, MRI is the modality of choice. This was a young boy who came with visual abnormalities, other neurodeficits, and he was diagnosed as adrenoleukodystrophy, where we can see the brain parenchymal changes in the typical distribution of posterior adrenoleukodystrophy. Vascular lesions like caroticocavernous fistulas, you see a very busy left cavernous sinus, and here is another patient with cranial nerve palsies showing a partially thrombosed intracranial aneurysm. As far as cranial nerves are concerned, once again, it is MRI which will show high resolution images with showing the optic nerves. This is a patient who came with diplopia, and here she is having a small nodular lesion which is enhancing in the contrast enhanced study because of a schwannoma or a meningioma in the Dorello's canal, thus involving the sixth cranial nerve. Neurovascular conflict is another condition where MRI is very helpful with MR angiography. The tortuous anterior inferior cerebellar artery is seen here and forming a loop around the root entry zone of the left facial nerve, leading to hemifacial spasm. Finally, this is the last slide. In this COVID era, one cannot but show changes which happen in the brain as well as in the paranasal sinuses and optic nerves in mucormycosis. This is, I think, the last slide, and my final conclusion would be availability of advanced imaging modalities is necessary for better diagnosis and management of neuro-ophthalmological disorders, and it's the combined efforts of ophthalmologists, neuro-ophthalmologists, neurologists, and radiologists which ensures best diagnosis and management of these patients. I thank you for your patient hearing.
It was really worthwhile to wait and listen to your talk, Doctor. It
Thank
was
you.
so very nice. Just one question I would ask.
Yes, please.
I mean, there's so much you could ask, but it's short of time. What is the relevance of using a stronger magnets in magnetic resonance?
Yes, stronger magnets, not only do they give better resolution images, particularly for visualization of thin structures like cranial nerves, even the optic nerve edema, demyelination, and also the scan time becomes a little reduced. Patients with orbital imaging, they tend to move their eyes. So we prefer to take images which are slightly shorter in duration, comfortable for the patient also.
Thank you so much. So nice to see you and have
So nice to meet you.